This conference will now be recorded.
Right, so we continue with the communication with patients, and we on the third category of that, like difficult communications here. So the first one among them is difficult decision making. Second one, how we do when the patients are frustrated, patients or relatives, they're frustrated or they're angry. And the third one is how we deal with when there is a conflict in what we think is in the best interest of the patient and the choice of the patient. So let's have a little example. So let's say this first one. So this is one of the very famous recalls as well. It appears in the exam repeatedly, almost every exam on some day it appears. So this is Catherine Whitehead, NCDA. She has twin-to-twin syndrome. She had 27 weeks and 5 days. And she has attended with a scan which shows twin 1 lesser 5th centile and reverse end diastolic flow. I think some like a volume is also given less than 5 centimeter, something like that. And then twin 2's growth is a 90th centile normal Doppler. And they probably have even some like pocket volume there as well, which is within normal parameters. So the situation here is that this woman obviously is at 27 weeks with where one twin is kind of severely compromised. So what are we going to do with this woman? So this woman attended from the scan. She had the scan and then she has been made to sit and wait for you to come and speak to her. So when you read this scenario outside the cubicle, the bullet points you need to take in mind is obviously number one, the one is extreme prematurity. Second, obviously, it's going to be a difficult conversation we're going to have with this woman. It's difficult for us as well, obviously, that we have to facilitate and take this woman through this decision-making process to take a decision and then obviously manage it accordingly. That's a bit tricky for us as well. So what are we supposed to include in this consultation? Yeah. So these are 3 main points we need to discuss here. So then again, how are we going to start? Are we going to take history first, or are we going to take, how are we're going to open up? This one is simple to open up. So go and greet this woman, Catherine Whitehead. My name is this and this. So can I, double check your name with you and also your age or date of birth? So do that one and then just check with her again. How would you like me to call you? So whatever she says, if she Mrs. Whitehead, call her Mrs. Whitehead or Miss Whitehead. If she say it's all right, you can call me Catherine, call her Catherine. Now, sometime I have listened some candidates saying back to the patient, call me this by their first name, say call me Safia. It's better not to give your first name to the public and the publicly. We usually keep ourselves as a Dr. Chabin, a doctor with your surname. So I mean, it doesn't make much difference, but it's just like one of those things it's just one of those things like you don't want to give your personal name and contact details to the public. So simply just say, all right, you have told your name anyway. I'm Dr. Jabin, so it's fine for her to call me Dr. Jabin. You don't need to repeat it. Just tell the patient, okay, so you okay? What do you want me to call you, Catherine? Okay, Catherine. So then you can open up a little bit that I understand you are carrying twins and you just have a scan done today and you are here to discuss about this scan. Yeah. So she will then start you with some information. Now, there are a couple of things now. The one is twin-to-twin syndrome. Are we going to explain her? That is something as well, because if we don't bring that in our discussion, we can't basically help her in decision making. Yeah. So instead of I'll straight away start by telling what twin-to-twin transfusion is, I will just simply say to her first, okay, so I understand you're carrying the twins and you had a scan done today, and then now you're here to discuss about your scans. First, I will invite her here to say, So could you please like to tell me first what you understand about the nature of your pregnancy? Yeah, that you're carrying the twins. And then she will start, yes, I know I'm carrying this twin. And usually they will volunteer that information, because the theme of this question here is not basically to explain twin-to-twin syndrome. Okay, the theme of this question basically is, again, as I said, like what information you will give about how we're going to manage it, right? So it's first just simply, but we need to address as what you understand. So just simply ask, tell me about what you understand from your pregnancy, about your pregnancy till so far, right? So she will tell you, okay, I have this, and this. Okay, that's fine, register it. Then the other second point, which mostly the candidates have asked me after doing different other courses or stuff, are the way they've been asked in the exam. They asked me, will this patient be, do we need to call fetal-maternal medicine? Do we need to send this patient to fetal-maternal medicine? How can we call the fetal-maternal medicine people in the night? Because probably it comes as a role player as well as come as a structured discussion as well, where actually your consultant is supposed to leave at 6 p.m. and then this is the patient and he wants to discuss the patient management with you. So there is confusion between people what we do. Number one, what is the pathway we have here in UK for MCDA or MCMA twins with TTT? Is their booking will be started, their booking will be done right from the beginning with the fetal-maternal medicine unit. Okay, most of the unit, we do have fetal-maternal medicine consultant as well, whether it's a district general hospital like secondary care hospital or the tertiary care hospital. If, say, for any reason we don't have, it's just simple twins, and then define wherever they are in secondary care hospital. If obviously there is some complication, then it needs to be not only to be seen by the fetal-maternal medicine consultants, then depending upon the condition, as with the twin-to-twin syndrome, obviously this pregnancy may need some intervention, yeah, during antenatal period, then maybe immediately after birth as well. So even if we have fetal-maternal medicine, say for example in our hospital and our unit, if we don't have those advanced neonatal intensive care, or if we need to do any surgery for these babies, if we don't have those particular facilities available in our trust, in our hospital, we will be sending and getting this patient booked into that tertiary care hospital. Okay, so there's nothing to worry about. What are we going to do at this stage, right? So the second question I'm going to ask this woman, after asking what you understand about your pregnancy and about your twins, so she will answer me about that one, and then I'm going to say to her, so I hope that you have already been booked with our specialist doctors, we call fetal-maternal medicine doctors team. Yeah, if she is actually with twin-to-twin syndrome and she has come up with this scan, you are fine to assume that you actually are that tertiary care hospital. That's why she has come for her scan here, because she's booked here for her antenatal care. All right, so at this way you don't need to worry what I'm going to do with this girl now. Who do I call the fetal-maternal medicine? So, and then you can, just to make it more natural, she will say, yes, I have been booked in. Sometimes she might just volunteer the name of the consultant. If not, then I will ask her to say, okay, so which consultant care are you booked under? And when she says, okay, I'm booked under Mr. William so-and-so, then I will say, right, okay, that's fine. I will let your consultant know as well that you are here with this. Yeah. And then I will say, okay, so you then have, and I just simply say, so tell me, other than that you are carrying twins and they are sharing their blood supply and after birth, tell me, has there been any other concerns or any other complications you have in this pregnancy regarding your own health? Like, have you been diagnosed with any high blood pressure, diabetes, anything else, right? By saying that, actually, because I have to make a management plan, we still need that information. Yeah, so here I can ask her. So I will ask this. If she says, but I'm going to just put into one question, do you have any of the problems of these? If she says no, then I'm not going to worry about each and everything to ask. Right? Second question I'm going to ask about, so have all the tests which we do routinely as your antenatal care, like down screening, your baby scans is 20 weeks, have that all been reported normal? Yes, if she says normal, then again, I'm not going to go into further details, because if there is something not, the role play would have been given the instructions to tell you, right? My placenta is low, my this is this or this or this, right? She will tell you. Same way, if it's a structured discussion, this is how you will tell to the consultant as well, that I would like to have this information, and the consultant will give you that information, the examiner. Then after that, you know, so is this your first pregnancy? Obviously, you need to establish the right somewhere in the beginning or second pregnancy. If she had any pregnancy before, obviously, you will just simply ask her about has there been any, you know, were there any problems in your first pregnancy? At what gestation you deliver? What is a normal deliver? That's fine. You know, and then you know, just a couple of other questions, as I said, for every antenatal patient. Just ask 3 questions. You never forget, whatever the scenario is. Any risk of ET? You know, has there been any history of blood clots in yourself or in the family? And how you feel? Have you been particularly feeling low in mood, a loss of interest in things in the last few days? And do you feel yourself well supported, or do you feel happy and safe with your partner? And you know, I can understand in this particular scenario, we do know this would have been stressful. So we can ask her by saying, so you know, I can understand when you're carrying these twins, and with this a bit of complication that the babies are sharing their afterbirth and blood flow, how this has been for you and your partner. How are you, you know, coping with this? Has this been stressful for you at all? Yeah, that is something additional now you should identify from this scenario. And after that, then you will say, okay, so you had this scan done today. You know, we've been doing these scans to keep an eye on the growth of the babies, and also on the blood flow and the well-being of the baby. So we have done the scan today. And then you will explain her, and she would know already, obviously, the growth restriction in this small baby, there is a pattern of the growth. It's not that this baby has suddenly gone below 5th centile today. Yeah, we have been doing. It's worth asking her about the twin to twin. Have you had any intervention? Were you given any treatment? So if any ablation or any therapy has been done before, she can volunteer that as well. Yes, that was done, but it didn't work, or whatever. All right. And then you will say, okay, so as you know, we have been doing this scan to monitor the growth of both babies, and also the blood flow and the overall well-being of the baby. So you had this scan done today. And then you can explain by saying, so because now I know it's going to be a bit complex here again. So for this woman, I'm going to say, so you know, all the information I'm going to discuss with you, it can be a bit complex, and it may involve you to actually make, you know, some difficult decision as well. So would you like to call your partner with you as well? Are you okay for me to discuss with you? And then you will start by saying, okay, so you understand the first baby, the twin one, or your baby one, is growing smaller than the other one, and the water around the baby is less as well. So the scan today shows that the blood flow to the baby has severely compromised, which in simple words mean that either we need to deliver this baby, or because if we don't, and if we leave, there can be, you know, risk to the life of this baby. Yeah. Baby 2, you can test your twin 2, or the baby 2 is, yes, growing slightly towards the higher side, but the baby is fine. The water around the baby is okay. So you need to give that result as well. And the blood flow to the baby is quite normal as well, to the baby 2. Now we have given all the information to her, right? Now see what she says. Let me see. She might ask you some question. She still hasn't realized the severity of the situation because we haven't talked about, you know, the details, or she might just get a bit worried and just say, so whatever she is, just listen what she says and answer. If she asks you any question, answer. Otherwise, the conversation, the way the conversation should start from here, you should tell her by saying, so because of, you know, the reduced blood flow to the baby one, there are 2 different options now here which we can consider. The one is, so like this, the baby is compromised. So the first option is that we deliver these babies, and then we keep them in the intensive care unit. and provide this baby obviously oxygen and all the other support this baby needs. Okay, so that's the one thing we can do. However, now if we are giving her the option of delivery, then we need to obviously tell her what are the risks of this premature birth, right? And what we can do then, and then I said in previous stations as well, if we're telling some risk, then we straight away need to tell her what we can do to reduce the risk, right? So we'll say, okay, so because the babies are quite premature, they're only 27 weeks and 5 days. So there are some obviously risks and the complications which babies may suffer if they're delivered at this stage. So, you know, their lungs may not be still fully mature. There can be difficulty of breathing for these babies. There is a high risk of infection. And their brain development is not fully mature at this stage either. So these babies can have difficulties, you know, learning difficulties later on. And it's difficult to say that, you know, that the range of those learning difficulties can be from nothing, absolutely normal, to mild, or even very severe learning disabilities, which obviously is very difficult to predict. All right. So what we have done, we have told her is they may just be normal, mild, or severe. Yeah, the range can be from just normal babies to mild learning difficulties or even severe learning disabilities. So to reduce some of these risks, what we will do, then we will first, you know, put the continuous fetal heart monitoring for both babies to see the babies for the time being are doing okay. We will also need to do another specialist scan to check the blood flow to the baby's brain. Another part we called it, and then you can say middle cerebral artery, and we call this venosus ductus. So simple, I say the blood flow to the baby. That will also give us further information like how much time we can buy before, if you take the decision to deliver, before we deliver you. So we can give you some steroids which will help the baby's lungs to get mature and be ready to breathe. Okay, if you will make, you know, if you will consider, which we will give anyway, so you can offer, we will give anyway if you decided even not to deliver, right? So we will give those at this stage. And then also, if you would choose to deliver the babies, then we will also start you a medicine called magnesium sulfate in a drip that will help to increase the maturity of the baby's brain and, you know, reduce the risk of learning disabilities we discussed. So somebody asked me, will we admit this patient? Yes. When we are saying we will be doing these intervention, that means admission. But if you particularly want to say we need to admit you, that's fine. Start by saying we will need to admit you to do further scan and then do these. And then, so after that, these one else if the baby is born. So then and there, keep the course in your mind. So when you're talking about we will give you this steroid, we will give you magnesium sulfate, we're talking about the babies, neonates, okay? So if these neonates then afterwards deliver, what are we going to do them? So I'm also going to check that we do have 2 courts available in our, you know, baby intensive care unit for these baby to be looked after. I will also speak to the pediatrician and ask one of them, if they can, to come down and speak to you and discuss with you about, you know, all these things in more detail, right? So that's about if she chooses to deliver. So the other option is, you know, which is really the difficult option, but that is something you can, you may consider, that your baby too, who is growing well, and you know the blood flow and everything is okay for the baby. At this stage, if we delay the birth of these babies, even for a few days, a couple of weeks, that's going to you know, dramatically increase the chances of survival and reduce the risk of any learning disabilities or infections for the baby. So the other option could be that we basically give the full chance and opportunity to the baby too to have more time inside the womb and have more chances of survival. But in that case, the baby first, if we didn't do even anything, obviously the baby one, because it's compromised, that baby can die at any stage. Or sometime if the parents choose to give the healthier baby maximum chances of mature, then we can even do this similar procedure where we can stop the blood flow to the baby one. Yes, you will have the recordings. Somebody asked about the recordings. Okay, so then we can, stop that one and give the chance. But in that case, if you will choose to do that, obviously in between, give her a chance to ask as well, because I'm not doing as a role player, so I'm just telling you the theory bit. But in between, obviously, whenever you will say, we will do this, then you will say how you feel about it. Will that be okay with you? If this will be okay with you, okay? So then you will say, okay, so if you will choose this to give baby a second baby, then we will need to do that, cut off the blood flow to the baby one, and then we will keep a close eye and close monitoring on the well-being of the baby too. We'll be doing the scans, and then we will do a special scan called MRI of the brain, because sometimes the baby, if the one baby has died inside, there can be some release of toxins which can affect the development of the second baby or cause even infection, and even can put up into early labor as well. Okay, so it's important to tell her as well that even if she chooses second, we cannot guarantee we will be able to take her to 32 weeks. Yeah. And so this is the reason why in the beginning we need to establish with her that we need to have a difficult conversation with you and difficult decision making. Now this is going to be difficult. She is going to be upset about both situations. Yeah. And if she does, then obviously you need to say, yes, I can understand. It's really difficult, it's a situation and circumstances you are under, and it's really difficult decision making. Some people will just simply say she won't take too much of the dramatic emotions. They're very practical, and she will say, no, they're absolutely okay. I want to give my both babies equal chances of survival, so I would rather like to go for the delivery. That's okay. Yeah, then say, okay, that's okay. So I'm then going to make these arrangements for you. I'm going to inform my consultant and also your, fetal maternal medicine consultant you are booked under care, and also with the, and arrange your scan, which we need middle cerebral Doppler and stuff, right? And if she says no, okay, well, it's difficult. I don't know what to do. It's really difficult. I'm really upset. Then you can say, okay, again, give her the support and say, yes, it is really, it is, I understand, it is a very difficult situation we are in. I'm not going to say you are in, I'm going to say we are in. By saying that, basically, you're relating to that patient. This is empathy, okay? And this is difficult scenario, as I said, like as a clinician as well, be human. It's difficult for us as well, yeah? So yes, this is really difficult situation we are in. But don't worry, whatever the decision you will make with your, and your partner, we will facilitate that for you. So if she's not ready, you can say it's fine. You don't have to immediately jump to make a decision. For the time being, I'm going to arrange their specialist scan to check the blood flow to the baby's brain. We call middle cerebral artery, Doppler, and also put the CTG, continuous heart monitoring trace for both of the babies. And I start with, those injection of steroid to give you. I'm leaving some written information about this as well for you here, where you can read. And once your partner is here, I will come back, and then, I will discuss with you. If there are any further questions, I can answer, and then you can take a decision. However, we may not be able to wait too long to make this decision. Yeah, then what would you like to do? If the baby, after that scan and after putting that CTG, if the baby showed signs of distress, right? Or the baby's, it shows that the baby is really, compromised, then you may need to take your decision a bit fairly quickly. But beforehand, you have said to her, yeah, so don't worry, you can take some time. I do this. Meanwhile, you reassure her, I'm going to put these ones. So you're talking about your monitoring that I'm going to. That's a safety point. We can't leave her for hours or even without doing anything, yeah? So that's why you need to say, I'm going to monitor this and this, and then you can discuss. However, if the baby shows the signs of any distress, then you may need to take some quick decision. But we are here to give you all the information. So I go now and check the cards and ask the pediatrician to come and see you and inform my consultant, right? This is how, and then you can ask like any questions. And so when we do as a role player, obviously you will be considering chances to give her to ask questions, making sure you're engaging her the way you do. This one just a that one too. Okay, any quick questions about this?
Madam, can you just repeat the options for Ttts because my net was very down. I couldn't hear properly.
Yes, so there are two options we're going to give her. The first one is we will tell her that your first baby is severely compromised. The blood flow to the baby is compromised, which means if we don't deliver this baby, this baby can die. It can be life-threatening for the baby. So we need to first establish further well-being of the baby by doing, you will say, the middle cerebral artery Doppler and ductus venosus Doppler, and I'm going to put CTG and speak with the concern. And then you say, so the first option is that we deliver this baby, and if we deliver, this is what we're going to do. The baby's lungs may not be quite ready to breathe. You're going to give steroid, magnesium sulfate. I'm going to check the cards and I'm going to tell. And then you need to also say, because these babies will be delivering quite prematurely, there will be a risk of these disease, which is obviously, difficulty in breathing, infection, learning disabilities. So you will give that picture. And then you will say, so, and the other option, which rather is quite a difficult option. So we acknowledge that beforehand we start talking to her, is rather difficult option to consider. However, some parents may consider that, okay? So I will normalize for her that as well. We don't want to appear so robotic to say, well, the one option is you deliver, the second option is you let one baby die, or let us, cut off the blood flow of that baby, and you get the chances of second baby. So even when we're doing that, the way I have told you, if you miss something, you will be able to listen in the recording. So, but then if we are saying how that you can, you can give more chance for your second baby, and the first baby, we can do this. In that case, even we're not going to promise that, yes, then this baby we can take up to 32 weeks, and then we do cesarean section and deliver this baby or whatever, right? We will still need to tell her, however, there will be still a risk that you may go into early labor. Yeah. So that this is called informed. When we say informed decision, this is what informed decision means. We're not going to give her either scare from one option completely and give good hopes for the other option. You just, in a non-judgmental way, need to give, when you're discussing two options, you need to give all the advantages of both options, but you then equally need to tell the risk associated with that as well, and what we can do to reduce those risks. These three elements must always be there. All right, and then obviously check with her.
Doctor,
Ma'am, one question.
Doctor, no
Ma'am,
role of KCL here to kill that first baby and all. We should not bring that point.
No, we wouldn't say we're going to kill that first baby. I think you missed that part when I was talking about this. So when you listen this recording later on, you will be able to listen how to phrase it. Okay. The way we will say, okay, I just repeated that. The way we will say the second option is rather a difficult option. However, some parents may consider under these circumstances. And that is because the baby too is growing well, blood flow to the baby is fine, water on the baby is good as well. So, we could choose to give more time for this baby to get more mature inside the womb by not delivering these babies at this stage. However, this means the baby one whose blood flow is quite compromised now may die. Okay, so first one will be may die, or sometime your consultant will discuss with you the option. They can choose to actually block the blood flow to that baby to give, because if the one baby dies, there can be some release of toxins which can otherwise, flow to the other baby and cause problems. So that will be discussed in detail if you would consider that option. So I wouldn't go in much more detail beyond that. However, if you would do that, then we will keep in close monitoring of the second baby. And for that one, we will be doing this scan and a specialist scan called MRI of the brain. We will be doing that just to make sure that that baby's, the growth and that is not affected. However, there will still be a small risk that you may go into early labor within next few days. I remember before. All right.
Yes, wonderful, doctor. Thank you.
Ma'am, one question. If the patient will ask, I cannot decide, what will you do, or what is your opinion? Even in that case also, or even for previous one, if just want to go back to VBAC or discussing VBAC or elective cesarean section, if the patient will say, and we know that maybe
Okay,
VBAC
let's
is
not
more better.
okay. Let me stop here. So let's not mix the VBAC in that situation here. We do have the VBAC station actually somewhere. We will be discussing that as well. Okay, so in this one as well, I did discuss, right? That when we will finish talking about both the options, then we will ask her what she feels, how she feel about them, what would you like us to do, right? So give her that question first. Now, there are two possible answers this woman is going to give me. The one is she will say, no, it's okay. I can't, be selective and just, choose one baby over the other. I would rather like to deliver, go for delivery and give my both babies equal chances of survival, right? So that's the one option. If she does that, that's fine. We can say, okay, I'm going to go speak to the consultant and, pediatrician, I'm going to make these arrangements. If she says, well, I don't know, to be honest, what to do. It's really difficult. And she go really stressed as well. I'm not going to force her straight away. So I'm going to say to her, okay, so if you feel it's difficult for you to take any decision immediately, you don't need to rush for the decision straight away. You can take some time, okay? Meanwhile, I arrange, go and check the baby cots are available. I give you those steroids. I'm going to speak to my consultant. And, when your partner is here, I'm going to leave some written information here as well. And when your partner is here, have a discussion with him and then let us know. I will come back after seeing a couple of patients to you to discuss. And then, answer any questions if you have, which may help you to reach to some decision. Meanwhile, however, it's very important that I make sure that the baby one is okay and we can wait for a few hours. For that reason, I'm going to arrange your specialist scan, the middle cerebral artery Doppler you need to explain her. And also, I'm going to put that continuous heart rate monitoring for both babies. All right. So, so if during the monitoring at any stage we find that the baby is showing the signs of severe, compromise, then you may need to take a quick decision. Is that helpful? Yeah.
Yes, ma'am. Thank you.
Right. So some other example of difficult communications when the patients are frustrated, unhappy, or angry for some reason. So sometimes the candidates ask me, the participants of course ask me, oh, I thought that was angry patient station, but that actually was not angry patient station. There's nothing angry patient. There's nothing, this patient. The angry patient can be only in one situation. If we have made really error and we have done some negligence, right? Then yes, that patient is angry patient. Otherwise, the way which we feel they are angry, they're not actually angry. They're frustrated. They're unhappy for something. Yeah, they are stressed. So we need to support them instead of being, defensive, thinking, oh, well, I'm not going to go near to this thing. No, you again, just like the last we discussed about androgen insensitivity syndrome scenario, if we need to explain them, we have to still explain them. Okay, so this question appeared, this station appeared in this exam, and some people found it was very tricky to talk to this woman. So I let you all read this letter. So this was the GP letter regarding this woman. So this was, so let's call her Joe Hirsch, was 38 years old, and the GP writes that she wants to get pregnant. Mrs. Hurt and her partner are trying for pregnancy for last 2 years without any success. Her periods are quite irregular and she always has prolonged cycle, with every cycle being 4 to 75 to 120 days, like prolonged cycles. So it's going more towards oligomenorrhea. Yeah. Her BMI is 42, and I feel she has polycystic ovarian syndrome, which seems to be cause of her infertility. I have discussed with her importance of weight loss to improve her chances of conception, but Mrs. Hurst becomes quite frustrated on topic of weight loss and now does not even want to listen anything about her high BMI and weight management. She declines to undergo any investigations of fertility and want to embark for pregnancy straight away. I've tried clomiphene citrate for induction of ovulation in last 3 cycles without any joy. Now, I don't know whether the scenario was exactly like this, right? I just have created the way the students who gave the feedback, obviously after the result, the story was something like on history taking as well. So sometimes there is a large chunk of important information which you will get from the patient that might not have been given outside the scenario. But the girls told there were quite few papers outside, before starting the station, about which was telling, anyway, collectively this was the information on history taking or asking. So how to do it? Now, when it says, now we clearly know BMI is something really needs to be addressed to improve her chances of fertility. But then it says she doesn't want to even talk about this, how we are going to do it. And then I have a few queries coming from different people to say, how then, if we're not going to say you're overweight or your weight is more or blah, 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 how are we going to do? And how are we going to say? Again, nothing to get nervous about this, okay? And this is not unusual. This happens many times. Okay, even people with chronic pelvic pain and difficulty, they also come and they also appear frustrated and unhappy when we start, they start in a bit argumentative way. What I'm going to do, the way I deal with these patients, no, yes, that's fine. Thank you very much to this GP who basically have kind of alert me as a colleague that I need to be really sensitive about. And I need to give a little bit thought how I'm actually going to communicate with this patient, yeah? So I can actually prepare her to listen and do whatever is really required. So the way I will speak this woman, go in, introduction, Joe Hurst, blah, blah, blah. My name is Dr. Jabeen. Can I take your name and date of birth? What would you like me to call you? I'm not going to be really nervous here and showing already I'm sitting tight who I'm going to speak to, or I'm expecting you're going to shout at me and being angry. No. I'm relaxed and open and non-judgmental. So I will say, okay, so I have received this letter from your doctor, from your GP. He has sent to me that you've been trying to get pregnant for last 2 years, but not have been successful yet. Okay. After that, now I'm going to invite her to tell me. Okay, so just tell me more about, yeah, or I'm going to say, okay, so tell me then about, the details, like how long you've been trying, what has your GP done till so far? Have there any tests been done, right? I know you say she doesn't want to have the test, but I'm just going to say, so what have they done already? All right, tell me about it. And then I'm going to sit and listen to what she says. Now, this conversation is important again, okay? Listen carefully now what she says. So she will start, and she started, the girls told. She just said like, okay, well, I have been, trying for 2 years, and I have been to the GP, and the GP, just is sending me and say, I need to lose my weight. I have done everything which I could do to lose my weight, and it's not working. And, I don't want to really listen anything about this now. I really want to start the pregnancy. And then, either as a part, if you have initially said, tell me what your GP has done till so far, she might just tell herself, the GP has given me some tablets, a clomiphene to, give me induction, help me to get pregnant, but that hasn't worked. Or if she hasn't, so whatever she tells, just quietly listen and write down. All right. I'm not going to talk about her weight at this stage. Then I will say, Okay, so then you take the history. Then you say, okay, so I will need to ask you a few more questions, some more information then that will help me to, you know, work out what may possible reasons can be for your infertility and what we can do to help you to get pregnant, right? By doing this now, what I'm doing, I'm opening her. I'm trying to gain her trust in me, okay? That yes, we are going to do that. I'm not giving any signs of stress from my face or anything to her to say if it's something different. Okay, so she will open up a little bit now. She will start gaining some trust in me. And then I will ask her, okay, so tell me about, like, have you been using any contraception before, what that was, tell me about your periods, how your periods have they always been prolonged and abnormal. And then I will take a little history about the family, you know, has there been any history of infertility in family on both sides? You know, all those general questions you need to ask for infertility history, yeah, about the husband, overall health of the partner, frequency of their, you know, intercourse, and what they have done till so far. Have your doctor done any test on you? No, he hasn't, and I don't want to really go for that. I don't want to lose my time in that when I'm already 38. I really want to just get, you know, started with pregnancy. So the details were on asking, she told, like, you know, initially she wasn't wanting to get pregnant because she was busy making career and blah blah. I know she's really in a good stable state of career and it's the best time for her to get pregnant, but she's aware that she's 38, so she should really get pregnant now, because losing any time from now onward will be reducing chances of her fertility. Okay, that's fine. I can understand. My answer will be yes, I can see that, and I can understand. You're right. Okay, let's you know, let me explain you first. What are the possible causes? Yeah, which can result in infertility. And then I will say, so normally what happens? The ovaries produce egg. Yeah, simple. I'm going to make a quick picture. I will say, so what happens normally? The ovaries produce egg every month, and they produce hormone, you know, which cause the thickening of the lining of the womb. And when the sex happens, the eggs then get matured, you know, under the influence of hormones, and that at certain level, at certain size of that egg, and because of the effect of certain hormones in the body, the egg actually, you know, rupture and get released from the ovary, taken up into the tubes, and then the sperm meets the egg in the tube, pregnancy starts there, and then pregnancy travels down into the womb and get implanted. All right. Now, by doing this, now what I have done, I have actually explained her the role of hormones. I have explained her the, you know, the egg formation, and we need to, you know, check that as well. I've explained her pregnancy starts in the tube and come down, so that give me a chance to, you know, help her to understand the tubal patency check, and all those are important as well. And then I will say, so that means if there is a problem at any stage, say for example, for any reason, if the ovaries are not making the eggs, there can be various reasons. There can be some imbalance of hormones in the body, you know, because of some other disorder or hormonal imbalance in the body, which is actually affecting the hormones which help to mature the egg size to release to certain size, and then get rupture and release from the ovaries. And here now I'm just gonna slowly squeeze in weight as well, and then I will say, so and these hormone, there can be different reasons for the hormone imbalance as well, and in some women, if the weight is above certain range, that can also significantly contribute to the hormonal imbalance, in a way that the ovary is either not producing the eggs, you know, or those eggs are not maturing to the certain size which is required to get pregnant, or those eggs are not being released from the ovaries. So that can be one reason. And in some women, their ovaries might be producing the eggs, they're getting released as well, but there may be some block in their tube or some problem in the tube, because of which the egg and the sperm can't meet or the pregnancy can't start, right? So for that reason, we do check. So when I was talking about the hormones, I will say at that stage, so for that reason, when we start to try to find out the reason, we like to check the certain hormone levels in their body to make sure that the egg is being formed and released. Then yes, the tube story, and then with the tubes there. So we like to do this test as well to make sure the tubes are open. All right, and then obviously very simple and basic test on the partner as well to check the semen of the partner, to check, make sure that they're producing the number of sperms and the quality of sperms is quite within the normal range as well, right? So by doing this, now I have all started. No, I will say maybe before I start, she might just start saying that I have done everything to reduce my weight, blah 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 blah, and that's no. I'm gonna, even if she gets angry, I'm not going to address the weight. And then I will say, I absolutely agree, and I can see that it must have been quite hard for you to, deal with this weight. However, at this stage, we do not know whether it's only your weight which is contributing, right? So first reassure her, first give her, because when we say you're overweight, she become and we all become defensive, don't we? If anybody tell us, well, you look like you have put on some weight, we all start doing, oh no, yeah, because of the lockdown, because we don't like hearing this, right? And if we are telling her your weight actually is responsible which you're not getting pregnant, she's not going to take it. So acknowledge first by saying, yes, I can see and it can be, and I understand it can be quite difficult to lose weight sometimes, and particularly if the hormones are not working normal in the body, if there is an imbalance, then losing weight become even harder. All right, so then you can say, okay, so tell me then, no, she will be a little bit, okay, so then you can say, okay, so and then I have reassured as well by saying that we need to do these tests and check, because your weight may not be the reason for it anyway, right? So we need to do these tests. Now, she will be very stupid if she will still say, no, I don't want to do any test, right? She will say, I don't want to do any test if I wouldn't have explained how the pregnancy happens, what are the possible causes people don't get pregnant. I haven't focused her weight, because in real world as well, we don't know, if nothing has been done, ovulation has not been checked, nothing has been done, how we can say by certain she has polycystic ovarian syndrome, and it's only the weight which is responsible. Yes, we do know reducing weight will increase the chances. Weight is also important to be lost to make the pregnancy and reduce the complications of the pregnancy as well. But at this stage, I'm not going to simply just totally focus on the weight. So I will say, so yes, so that's so she then probably said, I know what to eat, right, and all that stuff. But then I will say, I acknowledge and say, well, yes, but if there is hormone imbalance in the body, which can be sometime in a condition, we call it polycystic ovarian syndrome, where because of the hormone imbalance, people can put on a lot of weight. Okay, so I'm doing other way around. I'm telling her that it's not your fault you have overweight, that hormone imbalance can make those people to put on weight. And then, their ovaries are not producing egg and stuff. So it's very important that we do this very simple blood test. It can be, done just in one cycle. It won't take much of time to check those hormone levels to make sure they are within normal range, and also to check that your ovaries are making egg or not. And we also do the semen analysis test of your partner to say if the sperm count and quality is within normal range. Then the next step, we can check your tubes as well. And along with all this parallel, we can, help and facilitate you to, do some other measures to try to help bring your weight down. Because it's not only that the weight may not be the reason of you not getting pregnant. However, bringing weight will be helpful, because there can be quite a lot of complications in pregnancy, like developing hypertension, diabetes, and then a lot of complications and problems for the baby as well if the weight is above certain range. So now I'm giving her the hope of pregnancy. I'm giving her that picture as well. I've correlated, I've interlinked everything so together. She can't now just go take her knife out and say, I'm going to kill you. Why you say the word weight? Why she was angry and why she's frustrated? Because till so far, the scenario and the information she's given, she's clearly telling she basically has not been investigated for the cause of her infertility. No, the GP has not done this, but from the symptom, it's fine. Yes, sometimes if the women have a leukemia and she has hirsutism and all that and weight as well, we can't make diagnosis of polycystic ovarian syndrome. But then at the same time, we don't know whether she's ovulating or not. People can have ovarian syndrome and they may ovulate as well. Okay. So this is how you will actually address that kind of forbidden word you can bring, and she will be fine. And she said to the girls as well, they say, everybody keeps saying weight, nobody's telling me exactly why and how the weight is causing and why I'm not getting pregnant. And do you need to do any test on my husband? And then, you know, most of the people are still then saying, yes, we can do test on him as well, but and then she said, I don't want to lose the weight. No, these are very simple tests. They can be done within your 1 month, you know, just 1 month cycle. You know, that is important. And if you just blindly keep trying different things, the chances are that we will be losing more time in that actually, without understanding what is exactly the reason, how we can actually correct that reason and help you to get pregnant. All right. So that will give a clear understanding now. We have also told, yes, the weight could be, but there are all other possible reasons as well. So we basically, this was a simple case basically to start first consultation of infertility, explaining her the possible causes, explaining her the test, and then address the weight alongside. But the people become anxious, also taking that certainly the weight is, and everybody is then going beating around the weight. So then just say, you know, while we do this test at the same time, then I can arrange your appointment with the nutritionist as well to help you with that, blah, 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 some active weight loss program. And then once we will start doing something, and then, you know, after the test, then there was another clue as well. She has been, even if she's PCOS, these women, we can give them metformin. Metformin also help them to lose their weight, right? So that was another thing as well. By doing some of the tests, then we may consider to start you a medicine called metformin, okay? That will help to correct those hormonal imbalance in there. Obviously, we're talking about insulin resistance and stuff. And that actually can help you lose the weight as well, right? So this is the thing now we need to do. To do the test, start her on metformin, and do semen analysis and stuff, and then say, we will take things from here. How you guys feel about this station now?
Very easy and very nicely explained. Very nice. Thank you.
So, someone asked about, do we need to do insulin fasting? We don't need to talk to her about the details of all the tests, what we will be doing. There won't be time to do that anyway. It's a lot of this, again, conversation, helping her to understand what is causing her, you know, and what is the problem. So all you need to do is, we need to do some hormone tests on you, just to find out whether, you know, your ovaries are producing egg and they're releasing eggs, and then to check your tubes, and then some other tests as well, and semen analysis. So that's fine. Obviously, you don't need to say exactly what.
Madam, one question, like metformin is not licensed in UK, na? So how we can give her metformin?
But we do give them. So the medicines which are not, again, you need to just check, think in your mind, is there something basically which is recommended if this woman is? So what we said was, we're going to do this certain test, and then, yeah, we're going to first do this test, and then we will start you on this metformin. So if she falls in criteria of PCOS, then the guideline says give metformin, yeah. So
yes,
then we can give her metformin, all right? But then when I won't go into the details, it's not licensed, but because your bell will go off long before that. So that will be like when we are talking. So if we are giving them any medication which is not licensed, we do inform them by saying that this medicine is not licensed to be used in this particular condition. However, this has been used for such a long time over the years, and it has been found to be safe, and there has been clear advantages of this. All right, this is how we explain them when we give them some medicine which is unlicensed, but it is recommended, and we have a safety data about that.
Thank you, ma'am.
Okay. Third type of difficult communications. Any question about this one, or not particularly again about this one? Now, listen this recording again when you will listen, and try to, again, I haven't done exactly how the scenario should have been played if I do, okay? This is a part of course and we can do that. I just wanted you to learn from here how you approach your patients when they're frustrated and when there is something which clearly annoys them, how basically you are supposed to explain them those things and bring to that then. So make them to understand first the normal process, whatever that is, and then without directly referring that to her, as we wanted to bring the weight, the way we introduced the weight in ovulation was, what we said was, in some women, for various reasons, if there is some imbalance in their hormones, their ovaries may not be producing eggs, or those eggs are not getting mature to the size they are needed to be, or they're not releasing the eggs. And there are various reasons for that hormone imbalance. And weight beyond certain limit is one of the important contributor factor towards hormonal imbalance. Can you see then? Yeah, how we sneaked weight story there. Again, it's not again something you really need to get trained. It's normal and natural, and probably you do this all the time. But when we're preparing for the exams, we actually start making things difficult for us. We start making, we have to, you know, we try to go into some very sensitive and very artificial world. No, just act like a clinician of that day, please. I just say to them, don't go into exam, go to your clinic. Don't speak to the role player and examiners. Speak to your colleagues and to your patients. Okay? And try to put that, as Bhavna said as well, I say that to my candidates, right from today, please start practicing that on your patients. Do that to your real patients, instead of just getting a partner and then just practicing with them. And then when you go into the clinic or on the station, do something different. Right then. Okay. And hopefully this will be the last one for today. And then as well, like next Sunday, I will do another session. Hopefully the link will remain same. So you guys can join, time will remain same as well. I may not be able to advertise it again. So you can just log in into that and you can spread that to your other friends as well. Most welcome. Right then, so difficult situation, third type of situation, when we may need to take, you know, in a bit of, in a skillful manner, we need to speak to patients. And they can be when there is a clear conflict, which we feel is in the best interest, but the patient chooses to do something else. Right, so again, this was one of the scenarios from this exam, where this again is the scenario which appears almost in every exam, where a woman wants to have either a home delivery or she wants to have a pool delivery, and she do have a clear risk factor against that choice, and then how we speak to them. No, these again is not some standard way. It's my own way to put things to help you people to understand. So I will say it's a conflict, little bit of conflict, not that typical conflict, you know, when we say we will be taking advice from the court and blah blah blah. Conflict in a certain, in a gentle way. Conflict, I feel this will be better for her as a clinician, but she wants to do something different. In that situation, basically what we usually do when we think, the way we are going to speak, this is called negotiation, right? We're going to negotiate with her the options and this. So the negotiation means when we negotiate, then the way we do, we need to find it, okay, the other person also want to do what is, we're not going to totally, if I will go strictly totally against her wish to say, you can't do this, you can't do this, no, this, you just can't do this. She's probably not willing to take it. If I will be a little bit flexible for her actually to give some of what she wants or something closer to that what she wants, then she probably will be more willing to listen to me and not take the risk which she's taking. And she will be more likely to accept the safe option we are offering her. Okay. So say for example, So this woman was, so she's whatever the age and name, second pregnancy, and she has come to see you at 36 weeks of gestation because she wants to have a home delivery. And her previous child was just cesarean section due to fetal distress. So she has accepted to go for VBAC, try this VBAC this time, but she would like to deliver at home. So for simple, open up. So just to give you some more background, because obviously we don't have enough time to play as a role player here. So always ask the women maximum information, right? So I just give you the further background information as well, which the candidates have told me they gathered it after talking to her, obviously asking why you want this and blah, blah, all that stuff. So this woman basically the first delivery also she planned as a home delivery. And she started the labor at home, but then there was meconium. And for that reason, she was then rushed and shifted to the hospital. And obviously, there would have been clear fetal distress that she was just straight away rushed to the theater where she had emergency cesarean section. And she then described and also said that she was in a lot of pain and, she was quite traumatized and upset with all that which was happening. But the main reason she told was that one of my friends had hospital delivery, very common similar things. She has hospital delivery. There was a lot of intervention doctors did, which obviously this particular woman feels was unnecessary. So they deliver her baby with vacuum, and then baby ended up staying in the baby unit for so many days. So I don't want to do any of these interventions. I just want to have a nice home delivery. So open up. Introduction, my name is this, blah, blah, tell me your name, what would you like me to call you? And then say, okay, so open up. So this is your second pregnancy, 36 weeks. And I understand you're here to discuss about your plan of delivery. So, okay, so would you like to tell me what you want or what are you planning? All right, so then she will start, okay, so you use all these details. I want to have a home delivery and I have a cesarean section and it's fine. I'll say, okay, right, so you want to have a home delivery. So tell me about your first delivery and first pregnancy. So then she tells, okay, I have this pregnancy. I actually had a home delivery then as well, and this happened and this happened. And then they'll say, I'm really sorry that you had to go through that stressful experience. And then you had to be rushed to the hospital. How is the baby? How was the baby after that? And so just normal discussion again. And then you coming to that and you say, okay, so then I'm just again in a very normal level, I'm going to say, so yes, so once you have the cesarean section, the next time we actually encourage, what I'm going to say, encourage and recommend that women to be looked after under consultant care during their pregnancy and also to deliver at the hospital. Because there are some risks associated. And I'm just simply going to tell about the cesarean, and I will say, so once actually the women, once they have the cesarean section done, obviously, there is a scar on the womb. And because of that, during the labor, during the contractions, and when there is a scar, that part of the, that area of the womb become comparatively weaker. So when there are contractions during the labor, there is a small risk that, they can be, that scar can rupture and open up, which can result into life-threatening bleeding. And obviously it can be life-threatening for the mother and life-threatening for the baby. And can be really serious, situation and emergency. So for that reason, again, I'm starting again. I'm not talking to her or recommending. I'm just simply again starting first why we recommend the women with cesarean section to deliver in the hospital. Yeah. So I have told now that there is a risk of this rupture. So for that reason, we like to deliver these women in the hospital in the consultant-led unit because we can then monitor them more closely. We put a continuous, we like to do the continuous heart rate on the baby. So at any stage, when there is even a small, opening of the scar and the bleeding start compromising the baby, we can pick up it early. All right. So and then we can do whatever is necessary to save the life of the mother and the baby immediately without any further delay. All right, because sometime if the woman is actually delivering at home and this type of situation happens, we may not have enough time actually to get even to the hospital, you know, and that can be life-threatening. So at home delivery, obviously we can't do that continuous monitoring as well for the baby's heartbeat, which can really be an early sign, you know, as soon as even a small separation of the scars start happening. And then I will say, so after this information, how you feel? Yeah, I'm just simply saying how you feel, what your choice is. Now, hopefully at this stage you will say, oh, well, okay, I didn't know that, or if that is important, or mostly what happens because they want to obviously listen more about it, then they say, well, I live very near to the hospital, doctor, and you know, it won't take much time for me to be moved to the hospital. Yes, that's right, you said that, but as I told you already, sometimes this rupture and the bleeding can be so heavy, you know, that actually that can result into the loss of life of the mother or the baby just within few minutes if we are not able to detect those signs earlier, which we may not be able to do at home with just that intermittent listening to the heart of the baby. Okay, and then once that happens, then obviously the mother blood pressure falls down and she may become even unconscious, and then transfer of the mother to the hospital become even more challenging, and that become even more delayed. All right. Now after this, I don't see this woman will still say, no, I want to deliver at home, right? If she still says, well, yeah, that's fine, but you know, then I will be concerned now. Now I will ask, okay, no, that's fine, okay. No, I understand, obviously, no, without that information, you will be concerned about the baby well-being as well. So is there anything else which is bothering you that you don't want to deliver in the hospital? Yeah, we never know, there might be something else going on. Sometimes some abuse cases, and that person is working in the hospital actually, their partner or something. So you don't want to lose that opportunity either. All right. So we know clearly, we have told her, you rupture, you bleed heavily, you can die, baby can be life-threatening, we may not be able to save baby, we may not be able to. She's still saying, well, no, yeah, but I want to deliver at home. So I'm not just going to take that she actually is trying to be difficult with me just to give me difficult time. No, I will be the way around. I will be concerned, I will be worried about this woman. And I will just ask, like, you know, that I can see you understand that, you know, choosing this option to deliver at home can be dangerous and life-threatening for the baby. But you still will say, is there anything else you are concerned? Or is there anything else which is bothering you not to deliver at hospital, right? And if she says, no, yeah, no, there's nothing really, anything like that, then I will say, okay, then I have excluded it. Then I will say, okay. And she's just simply just said, no, I don't actually like the hospital environment and blah, blah, blah. Then I can say, okay, so what you could do, no, I'm going to give her options to make it a bit try to, no, I'm going to start negotiation with her. Okay, give and take kind of story. Okay, how you feel about, so if she says, well, no, I don't like that noise of machines and all that continuous monitoring and blah, 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 and that, you know, rushing the hospital environment give me stress and anxiety. Okay, yeah, no, that's not unusual. Some women do feel it bit and they want to make the labor process more natural. But obviously, because of the reason I have discussed you, it's important as well. So how you feel about if we actually give you a couple of, you know, visits and rounds to the delivery suite for you to become familiarized with the environment, okay, and meet our staff. And talk to our lovely midwives to say, like, you know, they will try to keep it as much natural and pleasant for you as possible. All right, so that's one option we can give her. If she says hospital environment is particularly I don't like, how you feel about this? If she goes with the option, that's fine. If she still says, well, no, I don't think so, that's going to make much difference, right? Okay, what we could do, however, we will still strongly recommend you to deliver in the consultant-led unit. But if you really feel that there's no way you can consider that, Then how you feel about if we arrange your delivery to deliver in our, we call it midwifery-led unit. The difference is you know, on the other side of our delivery suite or labor ward, delivery suite, but the environment is absolutely like home. The beds are like your home bed, you know, there's no intervention. We would like to, obviously, as a start, like it's important we, you know, monitor baby's heart rates continuously, but you don't want to, at least, you know, if there is any concern, then it will be a lot more easier to shift you towards that or to the theater if required, rather than being shifted from home. Okay, so even when I'm giving the midwifery-led unit option, I'm not saying that go on. I have first said, although whoever, we will still strongly recommend you to deliver and consultant-led unit, but if you really can't take it, then consider this option. If she still goes for that one, which is unlikely, absolutely unlikely, but if she still goes, no, I don't want to, then I will say, okay, that's absolutely your, you know, your choice and decision. It's your baby, it's your delivery plan. You have the right to take the decision. As far as you understand that these are the risks, you know, if that happen, yes, it might be just the delivery go very smooth and straightforward. But if these complications happen, they are life-threatening for you and for the baby. If you still want to go ahead with that, that's absolutely okay. I will discuss with my consultant, and then we will make a plan, all right, for you to have the arrangements for delivery at home, and also to keep the plan B in place, that if any complication happen, how are we going to transfer you and deal with that. Regarding when you're talking about the consultant-led unit delivery in the beginning, you can also add and say, when you are there, we will try to keep it, you know, as much natural as possible. We will not do any intervention without your consent and without explaining you. So even if any intervention is required, we will explain you clearly what it is. If you will happy for us to do that intervention, then we will do. Otherwise, you know, we won't be doing that. So I can reassure you that you will have the control on your birth plan. All right. So in this particular one, anyway, this woman basically, when she was told this, she was happy to deliver, and she said, oh, that's fine, I didn't know that actually. So that's all. Once she was reassured that you can actually, you know, we won't do these interventions without your consent, you will have the control on your body. She said, okay, but then she said, okay, but can I have a pool delivery from pain relief point of view? Well, that is something which can be considered. However, that may not be possible for the whole process of labor. Okay, so you may use the pool. So again, I'm not recommending may. You may use the pool in early labor. That's a good as your pain relief and to have a good experience. But as soon as you will enter into active stage and regular labor, we would encourage you then to come out of the pool. So we can actually, you know, monitor baby's heart continuously on that, because in case if you know those monitoring instruments for the baby in the pool, they don't work sometimes quite, and then if you know, if any rupture bleeding started, sometime it can become quite difficult and challenging then to move you and shift you from pool to the bed, and if we needed to take to theater, right? So there was a very good negotiation kind of thing in the middle ground. So yes, in the early part of the labor, in early labor, you can use the pool, and then you come out. Yeah. So this is kind of negotiation basically, right? So yeah. So this was the last one. We might need to do actually a couple of more sessions to complete what I wanted you to from our domains. Right. So how you feel about this now then?
Excellent session, Dr. Sophia.
Excellent negotiation, Dr. Sophia. Excellent.
Good.
I've never heard this type of negotiation. Thank you so much.
You're welcome. So yeah, so same time next week, and then following weekend, obviously our course will start. So I may not be able to do any further sessions. So Yeah, so anybody who's interested to book course with us, they need to do it soon. I don't take too many people in my sessions. I do not believe in listeners only option either. And I will strongly recommend you guys actually not to book yourself in any course as a listener only option, because that's not going to help you. Sitting and listening, it appears like, yes, we have learned this all and we are just going to deliver that absolutely lovely way, but it doesn't happen. Men is come to arrange, consolidate, and do all that within 10 minutes. That come only by practice. So you have to speak, you have to say, you have to listen yourself, you have to ask somebody else to help you to pick up, improve this, improve your tone, improve your speed, improve your volume, maybe improve this. Some girls are doing excellent, but the way they speak in such a monotonous way in the exam that they unfortunately fail because of that. So the course starts on 16th of July. This is the number you can contact who are interested. The fee is £550. We do 10-11 sessions. In each sessions 10 recalls at least. But in between, obviously, we do discuss other scenarios as well. And you continue with that sport till you pass, basically. So for any reason, people who have done this will be doing this course as an active participant. They are active participants. As I said, like they all must present. If they don't get placed in November exam, then when we will be running the course again next for May exam, they will have the access to listen and in between present as well. So then you keep doing that pass basically. So even if you have taken the exam, but God forbid, which should be unlikely, but if God forbid you fail the exam, then you still continue to have the access to that course. The people who do course with me, I give them feedback to individually tell the girls, you are ready. Yes, you should go ahead and apply for this coming exam. If not, I do tell people you're still not quite ready. You need to improve on this one. So wait some, if you listen to that, I can promise you, if you follow the training and follow your individualized tailored feedback, I don't see any reason why you shouldn't pass in first attempt. The other thing, before I take this responsibility, the people who do my course and want to pass as well, in last 10 weeks, you must stick only to my course recordings. The problem happens when you have done the course, you learn the things. Yes, this is how exactly it is, but then in between you do, which is fine before that. But the last 10 weeks or 8 weeks particularly, you must stick to one recording of your own course and the guidance from that mentor, so that you can develop your own specific style, just like Bhavna said. And all the girls, my girls who pass with a really good score as well, they have said, I have repeatedly listened this sentence, ma'am, your recordings, when we were doing the station, we could actually hear your voice in our brain. So that's what it is, practicing. The people who confuse themselves in the last few weeks trying to listen these recordings and then try to listen some other recordings or other free sessions and stuff. Before that, do as many free sessions you want to listen, make your own notes and make your it's fine. Gather as much you can. But in last few weeks, even if it's not with me, it's with anybody else, please stick to your one mentor and one style in last 6 to 8 weeks time, and just listen that one person's recordings and say your own, record your own scenarios, listen them, make sure have you covered all points within 10 minutes. If not, re-record it. This practice must happen. Otherwise, unfortunately, it doesn't matter how good the mentor is and how good the course is. You can't pass if you don't do all this, training practice. Okay. So thank you very much. Good. There was a good attendance as well. So I will be sharing these recording to you guys. It will be available on YouTube as well. So next Sunday, 11 a.m., same link, same time. Goodbye.